So I'm Kiersten. I'm a sexual health and HIV physician in Brighton, and in February I embarked on a PhD entitled Improving Access to Sexual Health and Sexual Wellbeing for Midlife Women, so that's women aged 40 to 65 years in under-resourced coastal communities in East Sussex. So I'll give a little bit of a background to why I chose this project, and then talk briefly about the findings of the systematic review that I'm just finishing, and then about the other work that I've been doing in the meantime and the work that I hope to come on to in the future. So I'd like you all now, just as a 1-minute exercise, to think about a midlife woman in your life. So a woman who's 40 to 65 years old. Think about, does she have a job? Does she look after children? Does she look after elderly relatives? Does she look after people in her community? Then think about the other pressures on her. Does she have stable housing? Does she have enough money? Does she speak English? And what are the circumstances around her life? Is she the one in 4 women in the UK who've been sexually assaulted? Is she the 1 in 4 women in the UK who have been a victim of domestic abuse? And then superimpose on this woman who's carrying lots of these shopping bags, superimpose on her symptoms of brain fog, sleep deprivation, night sweats, emotional dysregulation, very common symptoms of the menopause that most women will go through. So these are the women that I'm championing. These are the women that are very poorly served at the moment and really unrecognised. So I'm just, I thought it was important to spend a couple of minutes talking about why I chose this subject. So as I said, I'm a clinician, and in my experience, I've looked after a significant minority of middle-aged women from under-resourced coastal communities, started working in HIV in 2014 in Brighton. And these women on the wards often presented with opportunistic infections, so very advanced HIV. Why were they the ones who were presenting with advanced HIV? Why weren't they getting tested when they first went to their GP, kept going back, being told they had depression, being told they had maybe hypothyroidism, even though their thyroid function tests were normal, and then ending up with disabling, life-changing consequences of a disease that could have been treated very, very easily if they would have been tested earlier. Seeing women time and time again with vulval lesions that they were just too embarrassed to get help for until they turned into vulval malignancies. Seeing women who just couldn't go to their cervical smears. As a midlife woman, single woman, how can you bring your 3 children to an appointment when it's only at 8:30 in the morning once a week? Seeing midlife women who were presenting with advanced syphilis because they thought midlife women don't get syphilis. So these are some of the things that really prompted me to begin to think about how I could make an impact. So I've spoken a bit about why I chose women. Recently I found out that 12% of the NIHR Sussex research portfolio is about women's health. 12% now in this, 2023. We know that women's healthy life expectancy is declining at the moment, whereas men's healthy life expectancy is increasing. We know, as Carrie alluded to earlier, that women are often misdiagnosed, often wait much longer than men for similar diagnoses, even wait longer for pain relief for similar symptoms than men. Why is that happening? So that's why I've chosen women. Why midlife women? So I had to limit it somewhere. And I think with midlife women between 40 to 65, they're coming to the end of their reproductive life. They're coming to the beginning of, many are hitting the menopause, 51, 52. And the menopause is a significant physiological, psychological change. And at the moment, we're going through very rapid shifts in our cultural landscape about what midlife women are coping with. And then people have already talked about under-resourced coastal communities. I'm really, really interested in this massive deprivation that has just, seems to have been ignored, as the Chief Medical Officer pointed out 2 years ago. Coastal communities are kind of the under-researched, not known about pockets of deprivation. So that's why I'm really interested, and I'm actually focusing on Hastings, Eastbourne, East Sussex, because I had to really limit my remit, but of course I'm really interested in coastal communities across the UK. Why East Sussex? Well, this is where I live, this is where I got the funding, but also, shockingly, in East Sussex, there's a 19.5-year gap in healthy life expectancy between a woman in central St Leonard's and a woman in affluent Groombridge. So that's why East Sussex. And why sexual health and sexual well-being? Well, it's obviously something I'm very passionate about. It's something that's very stigmatised, something that we still seem to find very difficult to talk about, but yet it's integral to mental health, physical health, relationships, community cohesion. So just a brief overview of the systematic review that I've just coming to the end of having completed. I wanted to point out a few things that were relevant to our Sussex audience. So, of course, as part of a PhD, it has to be a big piece of work. So this systematic review was looking at the barriers and enablers to sexual health and sexual well-being for midlife women in high-income countries. And 2/3 of the studies, of the 76 studies that I looked at, were done in the USA. But still, I think there were some really relevant findings to our Sussex audience that are really transposable. So I used a socio-ecological model, which, as I'm sure many of you are aware, it helps you to separate work and findings into different themes, so intrapersonal themes, interpersonal themes, community themes, organisation themes, public health themes. The intrapersonal barriers to sexual health and sexual well-being for midlife women in high-income countries. I thought there was some really, because the reason I'm doing this work is to get things that we can do something about, not kind of, So the things that I think, I just highlighted a few things that I really thought actionable quickly and relevant, and things we can, they're not just up in the sky, things that we can't action. So obviously it comes up and again, the intersecting disadvantage of underserved groups. So if you're a midlife woman who's a bit older, who belongs to who's not heterosexual, who's not white, who is poor, and who has a poor education, who's a sex worker, you're much more likely to have real challenges accessing sexual health and sexual wellbeing services. There were clear findings about the poor breadth and poor depth of knowledge of midlife women about sexual health and sexual well-being and how to access services. So they have difficulty in differentiating between different sources of information. Is it credible? Is it non-credible? They use inadequate indicators to assess the STI status of partners. And is this something to do with the lack of evolving education? Is this something to do with the poor representation of midlife women in our media? But we really have to explore how we can really educate midlife women about their sexual health and sexual well-being and how to access services. And we know that mental health services are really, really struggling, and midlife women have some of the poorest mental health if you look at the statistics. And obviously poor mental health makes it much more difficult to access many services, including sexual health and sexual wellbeing services. And we know that midlife women have many competing priorities, not only on their time, but in terms of side effects, contraindications to treatment, limited treatment available. We need to make things as easy as possible to access services. A few things that providers can do to make things easier. So women, even nowadays, these are recent studies, women feel healthcare providers are ageist, sexist, heterosexist, racist, need more training, and reticent to initiate conversations about sexual health and sexual well-being. I mean, as a health, this made me really upset, but obviously it's what's coming out of lots of studies. We know that from the studies, healthcare providers have a strong appetite to be educated. And how can we incorporate this better into their training? They want to know how to help women, midlife women, with sexual health and sexual well-being. So we need to focus on how we can help them to do this. Community factors. So we know that stigma pervades all of this. But I wasn't quite so aware how much age and sex are these cultural factors that really affect access to services. So midlife women really have a barrier to buying condoms. They see them associated with youth. They see help-seeking behaviour for sexual dysfunction as inappropriate for as you get older. They distance themselves from young people's risky behaviour while at the same time behaving in a similar way. And there's some really interesting things that come out about how women are socialised to minimise discomfort, which obviously prevents access, and how women and men frame help-seeking for sexual dysfunction in terms of erectile dysfunction rather than in terms of other things that might affect sexual dysfunction, for example, vaginal dryness. There were some really interesting things that came out about intergenerational factors. So, for example, that younger men expect midlife women to be lower risk, so they expect to have condomless sex with midlife women. But also some really interesting enablers to having access to services, like young relatives explaining to midlife women about sexual safety and how that's evolved over time. Oh, okay. I'm just going to speed up a bit. So there's obviously really important public policy, organisation factor changes that we can make as well, but in the interest of time, I'll just skim over those quickly. So just to really briefly mention the future work. So the rest of my work, my PhD work, will be a qualitative study which I'm about to begin, which is focus groups and interviews, and then qualitative work in terms of really working out what the enablers and barriers to access are in Sussex. I've recently set up a KSS Women's Healthcare Research Network with Lucy and Sam, who will talk about that a bit more and the importance of that. And I'm also in the process of setting up a coastal network and research network, which I'd really like people to join if they're able to. I think in the future, like we were talking about embedding research in the ICS, I've really been petitioning for a longitudinal study of midlife women in East Sussex, especially underserved coastal communities, because I think a longitudinal study will be the only way that we can get proper data about these women and how we can move forward in helping them. So in conclusion, I want to thank my supervisors. I want to thank the people who gave me the money to do this work, which is BSMS and the University of Hospital Sussex. And I've got 3 boys who obviously understand the importance of looking after middle-aged women.